Hi. Hello, everybody. Welcome to Knock Knock Hi with the Glaucomfleckens. I am Dr. Glaucomflecken, also known as Will Flannery.
I'm Lady Glaucomflecken, also known as Kristen Flannery.
Excited for you to join us this morning. We're going to talk
Afternoon.
evening, whenever it is. We are. We have a little bit of internal medicine for you today.
Yeah.
I hope you're excited for that.
It took me a very long time as a non-medical individual married to a medical individual to understand what internal medicine meant. To me, that is just
From an outsider, I can see how that could
it
be
is
confusing.
nonsense. It's like, what does that even mean? Internal medicine as opposed to what? External medicine?
Yeah, it's like
isn't it all internal?
it's like
It's your body.
Everybody except dermatology.
Right. Yeah, and then you explained it to me, not quite that way, but something similar, and it still it took me a very long time to nail this down, what this
I
is.
never really considered internal medicine. Since we're going to be talking with internists, I figured now I would talk about why I did not choose internal medicine.
All right.
Does that seem reasonable?
Yeah.
Okay. So I am not a hospital medicine person.
No, you don't like the hospital.
I do not. I don't like the hospital. And I think it's because I like fast paced.
Mm-hmm.
Yeah, my attention span wanes
Yeah.
after so often.
Mm-hmm. This is true.
You absolutely know what I'm talking about.
I do. I have to shorten what I say to you every single day.
That might just be because I'm stupid, but
No,
I
I
don't.
can just watch your eyes glaze over if I say like 3 full sentences back to back.
It's like when a med student comes on to ophthalmology who just wants an easy rotation, and I start talking about like glaucoma.
Yeah, exactly.
You can see the light drain from their eyes,
and they're just enduring it. That's how it is.
I'm just gibberish coming out of my mouth.
Yeah.
So I didn't like the hospital. I didn't like the pace. I didn't like how long rounds were. You can tell because I make fun of it all the time. And I liked having a defined end to my day.
Yeah.
And so outpatient medicine, that was where I needed to be. Now, outpatient medicine is not perfect. It's tiring. It's exhausting, but I know it's going to end.
Right. You know what time you're leaving.
I don't, I know I'm not going to have to admit a patient at, 5 o'clock right before I'm planning to leave. And that would prolong my being at work for a couple hours.
That's true.
Now, people are listening to this are going to say, well, internal medicine does have clinic. We'll hear from Dr. Paul Williams, who does a lot of outpatient. But there's still a little bit of inpatient.
Well, I think in
hospital
general,
scares me.
do they have, is internal, this is a serious question that might be a stupid question, but is internal medicine only academic? Is there such a thing as private practice internal medicine?
Yes, there's.
Interesting.
Yeah.
Okay.
There are entire hospitals that don't have residents that have just doctors working.
Yeah.
Now they might not be in private practice. They may be employed by the hospital system. But then some hospital systems contract with private practices.
Mm-hmm.
And so they the contract says, okay, you have to come and cover our hospital.
Right.
Same way I cover certain hospitals on call. Well, same thing for internal medicine doctors. And so I know there's pulmonology critical care private practices. They do weeks of inpatient service. So yeah, you can be in private practice or in academics.
Well, so what about private practice internal medicine? Still no for you?
Again, I think I like no, still no.
Just the hospital.
My mind is, it's not just the hospital thing, but it's also I like being very narrow focused onto one thing.
Yeah, that is how your brain works.
Yeah. So internal medicine, there's so many organs.
Mm-hmm.
There's the whole.
They all work together.
They're all inside, and they're
can't see them.
The body is full of them.
This is true.
And I just, it's not my thing. It's not my bag. I need one thing, one organ that's 2.5 centimeters long.
It's just all making a lot of sense in a different way when I think about it this way.
Well, should we hear from some actual internists?
Yes,
let's talk about our guests. We have Dr. Matt Watto and Dr. Paul Williams of the Curbsiders. So if you guys aren't familiar with the Curbsiders,
What are you doing?
They're for internal medicine education and also like practice management and leadership. They go
Mhm.
into lots of different areas. It's phenomenal education. You get CME for it.
Yep,
It's
that's
the
right.
it's check out their website, Curbsiders. They're on a lot of the social media platforms as well.
Yep,
And
and anywhere you get your
yeah,
podcasts.
yeah, and they have interviews with I've been on there. I talked
Yeah.
about the red eye with how it relates to internal medicine. So they always relate it back to that field. And so it's really cool to hear those in-depth interviews. Even
Yeah,
as someone who's not in internal medicine, I also enjoy hearing them talk about it.
there you go.
Sometimes it's in the vein of like, "Oh, I'm so glad I don't have to do that." But still, it's engaging and
It's
fun
almost like
nonetheless.
rage listening.
That's right. And so these two guys, they started it. Now they have a huge team, but Dr. Matt Watto is an educator, obviously a clinician, a clinician educator, an academic internist at Jefferson Health, where he's a clinical associate professor of medicine at Sidney Kimmel Medical College, and Dr. Paul Williams, also a clinician educator, primary care internist who also does addiction medicine. He's a professor of medicine at Penn State Health. And they both together run the Curbsiders. So let's get to it. Here they are. Today's episode is brought to you by the Nuance Dragon Ambient Experience, or DAX for short. To learn more about how DAX Copilot can help reduce burnout and restore the joy of practicing medicine, stick around after the episode or visit nuance.com/discover DAX. That's nuance.com/discover DAX. All right, we are here with Dr. Matt Watto, who told me I can call him Watto for this because everybody calls him Watto, at least his friends do, and Dr. Paul Williams. The Curbsiders are here. Thank you so much for coming on, you guys.
Excited to be here.
Yeah, no, a pleasure. Thanks for asking.
So the last time we talked was pre-pandemic. I came on the Curbsiders. I think we talked about ophthalmology eyeballs. Is that right?
Yeah, Will, we talked about the red eye. I believe that was the title of the episode, and I think I shared a story that in college I fell asleep too many times with my contacts in, and you told me that I deserved to not be able to wear contacts anymore, that I had lost my privileges, and that's stuck with me.
That checks out. That sounds about right.
Has that do you still take good care of your contacts? Has that stuck with you?
You know, I'm happy to tell the listeners an update many years later that I am back in contacts now on a limited basis, mostly for athletic pursuits. Playing soccer, I don't get my glasses smashed into my face. But yeah, I'm able to wear contacts again, despite you telling. So I guess my privileges are back, even though you told me they were permanently
Okay,
revoked.
good.
So
And
I'm glad.
Maybe some kind of probationary period.
that's right. And Paul, do you take care of your eyes? That's obviously important to know before we get started.
Yeah. Well, I mean, I am also a contact lens wearer. I will say that 1-800-CONTACTS will give me the call and be like, "Hey, you're due for refills." And I'm like, "Oh God, I have at least 10 pairs left." So maybe less than pristine, but I don't do a whole lot of sleeping in the contacts for whatever it's worth. I just maybe wear out their welcome a little bit.
Okay, I guess we can continue talking then. This is a screening tool we do for all of our guests, whether or not we can continue with this interview. So the first question I've been dying to ask you, the two of you, I'd love to get your opinion on ionized calcium.
Everyone wants to know.
Paul, we just talked about this the
We
other night
just
with
talked
Joel.
about
Do you
this.
want to? I feel like I'll let you take the first crack at this.
Oh, thanks. Because otherwise I don't feel like much of an internist. But it's so nice of you to ask. Ionized calcium, a big fan. If you truly need to know the actual calcium, if it's critically important, I think probably, Will, what you're alluding to is this idea of corrected calcium, which I think we talk about in the wards. We use the calculations, we show off to our attendings, but it turns out the evidence behind that is actually not all that strong and compelling. And in fact, the lower the albumin that you're using the correction for, the less accurate it becomes. It's actually based on a study of 200 patients at a single site that this correction formula came from. So as we've done retrospective studies, it turns out that actually just the serum calcium is perfectly adequate. And if you really need to know, then the ionized is the way to go.
I'll be honest.
We appreciate the question.
I'll be honest. I have no idea what ionized calcium is. I was just told by someone on Twitter to ask you that to make it seem like I have some street cred in internal medicine.
Yeah, he didn't follow anything you said.
I was very surprised that you went there as a first question. That was not what I was expecting.
Well, let's talk. I want to talk about Curbsiders first. All right, we'll get to some medicine stuff later, but this is when I came on Curbsiders to talk about red eyes and shame you for your contact lens wear. You guys had only done like 80 episodes. It was relatively early. I guess you'd probably been doing it for over a year at that point, but I just looked recently, over 400 episodes. Incredible. Well done.
Paul would probably blame me for this because at some point after the first year, which was a hard year, we were doing 2 episodes a month. And I was like, we're going to do an episode every Monday. And we've pretty much stuck with that. We've been doing the show we've been releasing episodes for close to 9 years now. So it's been pretty grueling, but we have a big team that helps out. And I mean, Paul's always in a good mood about it. He loves it. And there's nothing he'd rather be doing. Right, Paul?
Yeah, ideally on the weekend. But, if we have to settle for a Friday night, that's fine too.
Well, because it was just the two of you to start.
We had a couple. No, we had this wacky guy, Dr. Stuart Brigham, who was he was our third co-host initially, and then he sometime over the past couple years, I can't remember exactly when, he sort of took a leave of absence that became like a long-term leave of absence. But we recruited about 2 years in, we recruited people from social media, like our followers. We were just like, hey, do some of you want to help us make the show? And it became like this just kind of like remote working group. And there was, right now our Slack channel has 35 people on it. And that's been pretty consistent. Some people come in and out, but a lot of the people with us have been with us for about 7 years. And many of them have started their own shows and things now too.
I feel like I have a lot of like questions I want to ask just for my, like from a selfish standpoint as like someone wanting to sustain a podcast for years.
Mm-hmm.
And so can you give us like a tip?
Well, it sounds like the key to longevity is to have 35 co-hosts.
That's good. I didn't think about that.
Yeah, well, scudding is really, it's the key to any success in medicine in general, is if you can sort of get someone else to do the work, then you're in great shape. But I don't know, I'll speak like in seriousness, I'll let Matt answer it too, but I think for me, part of it has been, when we early on, we recognized that we were our own audience. So it was important to us to make content that we would want to listen to, or that was important or interesting to us. So, we've always made episodes, come up with clinical topics and came up with the questions based on things that we felt like we didn't know well enough or wanted to do better for our patients. So at least for me, and I think probably, I'm sure Matt would say the same thing, the fact that it's been able to kind of keep me up to date clinically and be able to take good care of my patients has been motivating above and beyond sort of all the extracurricular stuff that has come along with it too.
Did you struggle to balance doing it? Because eventually it started to gain enough steam and to where you felt like you had to hire or bring in more people to do the co-hosting, but you also have a clinical practice, right? Both of you do. And so was there a point where you were like, oh man, it's getting too untenable to keep doing both of these things. We need to expand and get more people in here.
Yeah, I mean, that was why 7 years ago we initially recruited audience members. And then there was a time where Paul and I had the deal, because I was the crazy one that wanted to do the weekly podcast, that like there was a time where I was like editing and doing the posts to the website and all those kind of things. And slowly over time, it started to wear on me to the point where I had to get someone else to edit. And then I had to find someone else to do the posts to the website. And we had to have other people checking over the blog posts before they went up. And so that's kind of where it evolved to allow us to keep doing this. But we didn't, we didn't have that in place at the time when it started, and it was slowly killing me. And and then, gradually I let go of that. I don't know if you know this, but a lot of people in medicine are type A personalities and control freaks. And that makes it hard to let go of things when you're running a podcast and you want like to have control over how many ums and ahs there are in the podcast.
Oh, excuse me.
Oh man, you are speaking Kristen's language right here, because I am the exact same way, except with with much lower stakes because all I do is wear costumes and pretend to be other people. You're actually dealing with, real medicine that you have to get accurate, like, or you're going to hear from it from hundreds of physicians telling you that you're wrong and that I'm sure maybe you already do. Do you get a lot of pushback? I mean, I'm sure there are topics that are pretty charged in the academic medicine world. Does that weigh on you? Does that just make you want to quit sometimes?
Paul, what do you think?
No, I think part of the genius, and I can say it's genius because Matt is the one who came up with it of the show, is having somebody else be the expert. So we have a
Mm.
really fairly stringent vetting process, and I think we try to be very explicit when we're diverging from guidelines or we're doing expert opinion. But for the most part, the medicine's being taught, like that's why we have someone who's an expert in that field teaching the medicine. So even if it's something that someone's not happy with, they can't be mad at us. So we're still able to shift the
That's so
blame to
smart.
somebody else to some extent. So some episodes
Don't
we get a
shoot
little
the
bit of pushback
messenger.
on, but other episodes, for the most part, we don't get a whole lot.
Did you get any people on my episode? Did they get mad at me? I didn't hear about it if it happened.
I think when so we didn't have it. I don't think we have many ophthalmology listeners, and I think the average internal medicine listener, like you could have been telling us all false information, and none of our listeners would have known. So it didn't. That's why it was. We knew you were a safe guest. We weren't sure about. We knew you about your comedy skills. We weren't sure about your
Uh-huh.
actual doctor skills, but we
Yeah.
we were like, this will be fine. He could talk about a red eye. So
Well, I'll tell
that's
you,
why we had you
people
on.
people are still confused about what type of doctor I am. So whenever I do post a video where I actually give like ophthalmology advice and education, people are very surprised. Like, wait, I really thought you were a nephrologist, which is it's a very you know quite a compliment because I'm nowhere near as smart as a nephrologist.
I was going to say all those characters you're playing, you can't blame people for being confused. They don't know which one's real. I was talking to a colleague. I was telling them that I was going to be doing your show, and her husband's a neurologist, and she said that all the neurologists were upset that your reflex hammer wasn't good enough. And then another
Yes.
colleague mentioned that maybe you posted a video to make amends with that, where you showed a drawer filled with reflex hammers. Is that true?
Yes. So here's what happened. I did a video with my first neurology video was with the tomahawk, like the orange one, that looks like a triangle. I think they call it the tomahawk. I'm not sure. But then what happened was people mailed me reflex hammers. I had
Oh my
four
gosh.
or five reflex hammers that were mailed to my place of work because people don't know I didn't have an address, a PO box to send for people to send me things, so I got them at work, and it was like, what are all these things there? And I have 4 or 5 different types of reflex hammers, and so I featured them all in a video, kind of like some shady character would open up a trench coat and show like all kinds of stolen like Rolexes or fake Rolexes. I think that's the type of video I did with all the reflex hammers I have. Which are what am I going to do with all these things? I don't check. When was the last time I checked a reflex? I mean the cornea reflex maybe, but is that a real reflex? Oh, it depends on who you ask.
And also probably not using a hammer for that one routinely, I would have to imagine.
We're not hammering the cornea at all. All right, you guys. So I want to talk. I asked you guys to give us some stories like from your training because people love these, just coming of age in medicine type of stories. And this is great because we're beginning the new medical year coming up, and so we're gonna have a lot of new interns, a lot of new fellows, a lot of new attendings. And so, Watto, I want to start with you because I would say what's always so concerning for new interns is like you feel like you need to prove yourself. Like I deserve to be here. I have what it takes. And I can't think of a way to do that better than saving one of your co-residents' lives. So
Whoa.
can you please tell us the story?
Yeah, so I had a charmed year my intern year, and I think it like this legend kind of grew because I was working with this very smart second year resident, but she was very accident prone and, you know, she just had seemed to be a little bit of a black cloud. And so it's our first night on call. I'm really nervous. It's like a 24-hour plus 4-hour call. So I'm going to have to stay overnight plus another 4 hours the next day, tying up my work. And I'm really nervous because we're going to be admitting all these patients from the ER. And she's like, let's go get some dinner. The missions are going to start to roll in. And she's just like talking to me like casually. And she's like filling up her soup. And we're at like the station in the cafeteria. And she takes a sip of her soup just like as she's talking. And then she starts like choking and she's like, oh my God, Watto, I'm choking my airway. She's like, I'm having stridor. I'm like, what are you talking? I thought she was just being dramatic. I'm like, yeah, right. I'm like, give me a break. Like you just took a sip of soup. Like what is blocking your airway? And so like we go sit down at the table and there's some other residents there and she's like coughing and she's like flipping out, like trying to drink water. So the other residents are like, wait a minute now, just calm down. Like this is probably just I know you have bad things happen to you, but you just drank some soup. Just give it a minute and see what happens. So as we go back to our call room where we're just like going to wait to get paged with admissions, like she starts to like hyperventilate and be like, Watto, I can't breathe. I can't breathe. So what really happened, I think, is we walked down to the ER, but this became that like I threw her over my shoulder in like a fireman's carry and took her down to the ER. She was about to code and they actually did like they had to call ENT emergently. They sedated her, this part's true. They sedated her. ENT like put a camera in her nose down into her larynx, and there was a bay leaf that had been sitting on the top of her soup. It was actually like a hard piece of bay leaf that was like intermittently blocking her glottis, and like they had to remove it. And so she was just like, because they had given her all the sedation, she couldn't work for the rest of the night. So I'm on call still and I'm still getting admissions. And I just have like this like rotating group of senior residents that are just like, yeah, they're just kind of like phoning it in. And I'm here just like, crapping my pants, trying to cross cover calls from the nurses and do admissions. It was an awful night.
Oh,
But
man.
I guess, I don't know, Paul, from your perspective, this kind of like gave me a good reputation amongst the interns.
I don't know if you all know this, but Matt and I did residency together. We were in the same year. We like couples matched through a bunch of rotations, and he was there was no brighter halo than Matt Watto even before this happened. So like I think half the reason the seniors were not too worried about him was because like he already had a reputation as being amazing. But yeah, I think this probably helped solidify it.
Oh my goodness. Well, thank goodness you finally believed her.
Right.
Jeez.
Yeah, exactly. And Paul, when was the first time you saved your colleague's life?
No, if anything, I feel like I push people closer to the brink. Whatever Matt's doing, I'm doing the opposite.
I'm curious, what rotations did you guys start on your intern year? What was your first area of the hospital you were working in?
So we had this very bizarre thing. So I was new to the residency program. I didn't do medical school at the same place. And so my first block was like this weird hodgepodge where I was on reserve, but also did research and was supposed to do a QI project. And so I was terrified as a new doctor, but had no clinical responsibilities. So like, I'm just like, I didn't know where the bathrooms were. Like I didn't know how to do anything. So my first real rotation was then the ICU, where again, everyone was like already a month in, had a month of clinical practice and being doctorate. And meanwhile, I've been like at home kind of making up QI projects and stuff. So my very first day, my upper year was like, okay, I need you to place 3 NG tubes in these 3 beds. I need you to do these 3 ABGs, and then you'll come back and we're going to go over these electrolytes together. I'm like, I am so happy to do that. I also don't know how to do any of those things. And so it was, the first rotation did not, it was fine. It worked out okay, but it was my first one. My first real rotation was the ICU. So it was just about as out of the frying pan to the fire as you could possibly get.
Oh my God.
Wasn't that yours also?
Yeah,
Yeah, that was mine. Go ahead, Watto.
I was going to say I was on night float, which is it definitely like where you just show up at work and they're like, here's 50 patients. You're going to get calls from nurses. Like, just handle it. And it was me and a couple other interns and a couple second and third year residents covering the whole hospital at night and running codes and rapid responses. So it was definitely like a thrown into the fire type situation. And fortunately, I was with a very good group of people and we had a lot of fun. And there was a lot of pranking going on as well, I would say. Not on patients, on each other.
Oh, that's good.
Oh,
I started my rotation. My first rotation intern year was ICU in this. So it was a small community hospital, and I was alone on nights, which in hindsight, like not the best for patient safety. I don't
Well, I'm
know.
sure there were some,
Well,
measures
I
taken.
had backup.
Yeah.
There was this remote ICU monitoring system. It was the voice of God that would like reach, like would tell me things, whenever, I don't know, something was happening. And so it was terrifying. That first month, it is really trial by fire.
I want to hear more about these pranks, though.
Yeah, so this is a little nostalgic too because Paul, this was like 2010, right? So Netflix had a streaming service, but it was still sending DVDs to people's homes.
Mhm.
So like when we had downtime, we would log into Netflix and just try to watch some stuff. And I didn't realize that I had left it logged in. So about a week into Night Float, I get home and my wife is like holding some like DVDs and she's like, what's wrong with you? Like, what's happening? And the seniors had gotten in there and ordered like Kama Sutra and like a whole bunch of like late night like Skinamax type films.
Mhm.
And my wife turns out was not into it, so that made me feel pretty good about myself. But yeah, I was like, what the how did this
Oh, it's
happen?
so good.
And then I get back to work and like the seniors were like so proud of themselves. I am still friends with these guys actually, and every time I talk to them, they still bring it up. They're like, "Remember that time I sent the Kama Sutra to your house?" I'm
Oh
like,
my
"Yes, I
goodness.
remember that. Thank you." Yeah.
That's a good
This
one.
feels like an elaborate cover story still.
Mhm.
Yeah.
Yeah, exactly.
Yeah. Let's see. The senior residents,
Well, these guys went
with
into GI fellowship, so come on. It's very believable. These guys went into GI fellowship. It's
okay.
that kind of
Yeah, it
character.
checks out.
It's
Yeah.
making a lot of sense. Now, neither of you guys are. Did you guys after residency? What were your career options like? Did you think about doing certain fellowships or going into private practice, or what was your thought process?
I had no plans. Like it's, I thought when I was in medical school, I was 100% sure I was going to be an emergency medicine doctor. And then when I was in residency, for a period of time, I was thinking about becoming an electrophysiologist, which is weirdly specific and also not anything I have interest in today. So I was offered a chance to do the chief resident year, which I took in part just to kind of reassess where I wanted to go with my life, what I wanted to do with myself. And probably my third year of residency, I started to really like primary care, but wasn't still convinced that was the job for me. So I did the chief year to kind of stall and figure things out. I was torn between that
Mm.
and actually probably palm critical care. But as I did more and more outpatient medicine, I really genuinely grew to love it. And then also, additionally, I was just exhausted, and the idea of doing more training sounded also terrible. So I stopped, both because I liked primary care, but also the idea of doing additional 3 years of training. I don't think was psychically tenable for me. So I think I landed where I belonged, both because of life circumstances, but also because I truly like it.
Yeah.
I was in the Air Force scholarship program, so I had limited options in the sense that they I would have had to do a fellowship within the Air Force, or I could just go right into the Air Force and work for them for 4 years, which I did, and I had a once again, a charmed life. Like I basically moved to San Antonio. I did some inpatient and outpatient medicine, pretty much the same exact job I have now and was working with residents and medical students. And I never got deployed overseas to like a combat zone. I was just like
Mm.
the only thing different is that I would have to wear camo to work every day, and I would have to get past an 18-year-old with like an AK-47 that was letting me onto the base. That was like the only difference between my current job and that job. So it was pretty seamless, and I enjoy it. So
I'm glad you don't
worked out.
encounter that in your normal job in civilian medicine. That's good.
18-year-olds with
That's good.
AK-47s.
That's
Let's
a,
hope not.
it's a good career,
Yeah.
internal
No,
medicine. You don't have
there's
to deal with that.
electronic locks on the doors. They're very serious about badging where I work, but they're not it's not as serious. And they would salute you too. That was the other thing. They would salute you cuz like if you're a doctor, you're automatically an officer. So, yeah, you get this
Oh,
I
really?
barely
Okay.
remember which hand to salute with at the time I first get down there cuz I'm like the least military person ever. But this kid's saluting me with while he's wearing a machine gun. It's great.
Well, Paul, I'm with you. I was after residency. I was like, I was done, and I would not have even done a chief year if that was even a thing to do an extra year. Because when you're done with residency, I think the last thing most of us think is, oh, I want more of that.
Mm.
That's yeah.
But pay me even less.
Like pay me. Let's give me some more administrative burden and let me do another year of residency. So I salute you for taking on a chief year of residency.
That one is a figurative.
Yeah, I know
salute.
I feel like there's a fair amount of discourse about like, is there ability to achieve here, or are you just sort of being an indentured servitude and actually just sort of being crapped on? I will say for my chief year, I found genuine value. Like you learn how the sausage is made, for better or for worse. Like you get an idea how to be an educator, you make connections, you figure out how hospitals work. Like, so if you're interested in academic medicine, which I was, like, it was an extraordinarily valuable experience that I would never do again, but I'm glad I did it that one time. I can understand a wild lack of enthusiasm too.
Yeah, that's actually a great point. I was just talking to somebody about that the other day, and the total lack of knowledge of how the healthcare system works that you get in residency and in med school, because you're just so focused on learning the medicine. You need to like be able to feel confident in your job and competent to do the work. And that's the one thing that just totally goes by the wayside. And so I didn't even think about that as a chief, you're kind of functioning kind of as an attending in a way. And so you're going to be exposed to more of the healthcare system type of things.
Yeah. And you sit on like the competency committees, which I don't even think as a resident I even knew existed, where a group of leadership sit around and just talk about the residents and how they're doing and how we can help them do better. And there's just a lot of stuff that's behind the scenes residency programs that I didn't have any real concept of until actually doing my chief year, at which point you're very much involved with the leadership. So it's not for everybody. If you're itching to go out and practice and you're not interested in academic medicine, I can't think of any compelling reason to do it. But if you want to be a part of academic leadership, I think there's real value to it.
All right, well, let's take a quick break and we'll be right back. All right, we are back with Watto and Dr. Paul Williams. Sorry, Watto. I'm just going to call you Watto. Watto MD. Watto.
Fair enough.
and what we're going to do, I want to play a game that I call Internal Medicine Lightning Round. This is, so I feel like one of the stereotypes that I play up in my internal medicine related videos is the fact that you all are so long-winded about so many things, which is, it's fine. Like it's just the way you are. And I think that's what draws you to internal medicine, because there's a lot to discuss in internal medicine. So what we're going to do is we're going to do a form of rounds, but this is going to be lightning rounds. All right. I'm going to just say a word or phrase, and you have 60 seconds to explain that thing to people. Okay. 60 seconds. That's it. That is it. That's all you get. All right. Bonus points if you can do it in a shorter period of time. Are you ready for this?
Oh, excellent.
I am, but only if Paul goes first.
Do I need to set a stopwatch?
Okay. Fair enough. All right. All right, Paul, you ready?
Yeah, lay it on me.
Okay. First one. Paraneoplastic syndrome.
Great. Thanks for starting with something easy. So paraneoplastic syndrome, if I were explaining to a patient, there are the direct effects of cancer, and then there's other weird stuff that cancer does that causes symptoms not directly related to the cancer itself. So if I had to explain paraneoplastic syndrome, it would be sort of all the stuff that you don't think of necessarily directly related to the cancer, but other symptoms that can happen because of a result of the chemical changes that happen with malignancy in general.
Damn. That was 29 seconds. That was fantastic. Okay, Watto, you're up. Here
I don't know if it was correct, but
No, that was good. It sounded
Okay.
It sounded great to an ophthalmologist ears.
That's right.
All right. Watto, Delta.
Oh gosh. All right. I'm gonna medical students. I don't even find that thing to be very useful. I rarely use it, and I won't even explain it.
Oh,
Paul, do you agree with me on that?
Yeah, I would say it's a formula used for one internist to impress another, which is what most formulas are actually used for, not for any clinical value.
Okay.
Like,
all right.
I don't.
That's fair.
Yeah.
That's fair.
Okay.
Watto, I'll give you a different one. I'll move on for you. Okay, here's yours. Goal-directed medical therapy.
I think a cardiologist would get mad at you because they're guideline directed, right, Paul? I maybe was scolded about that on air by a cardiologist. These are things mainly for heart failure or heart disease, medications that you should prescribe for patients because they're written in the guidelines, and the cardiology guidelines are so ironclad and supported by so much evidence that it just doesn't make sense not to prescribe these things. So that's GDMT, guideline-directed medical therapy.
Guideline-directed medical therapy. Okay, so not goal. I had it wrong.
Yeah.
Guideline-directed medical
Guideline-directed.
therapy. And that's how you can impress a cardiologist?
Yeah, just write, anytime you have a cardiology patient, just write like continue GDMT, guideline-directed medical therapy, or start GDMT, and then like it's always right.
Love it.
And
Okay.
30
That's
seconds.
good outpatient care. And just for the students and residents listening, if you're in the ICU, the answer is always reduce afterload. If you say that and just nod knowingly, the cardiologist are gonna be like, amazing, this guy, A+, future cardiologist. So 2 inpatient, outpatient tips for your learners out there.
Sorry. There's some valuable tips being shared
This
today.
is good.
Yeah.
I feel like I'm getting maybe like 3 weeks worth of internal medicine residency here. Okay. All right, here we go. Paul, GFR.
Glomerular filtration rate, which is basically a rough estimate of how effectively the kidney is functioning.
Done.
Wow.
Done.
Like 5
That's
seconds.
great.
Yeah.
See, you don't need to
Is there more
round
to it?
forever, you guys. Like this is look at how much we're accomplishing right now. Okay. All right. Watto. These are gonna get harder. Watto. Potassium. That's it. That's all you get.
Potassium is an
60
electrolyte.
seconds.
I would explain it to a patient. Potassium is an electrolyte that we follow because it's important for muscle contraction, including cardiac muscle contraction. So if it gets too high, way too high or way too low, you can die.
There you go.
How do you die?
Cardiac arrest, arrhythmia, cardiac arrest.
There you go. God, they're killing it. You guys are
25
doing
seconds.
awesome. Okay. I think all of these answers have been under 30 seconds, which is incredible.
Do you eat enough bananas?
I love bananas. There's lots of ways to get potassium.
We
I
never
feel
found out why he had his cardiac arrest.
Yeah,
so
that's still an unknown.
now I'm curious if it was your potassium.
Now that answer would take more than a minute.
That's true.
And several caveats and disclaimers.
That's right. Okay. All right, Paul. Admitting patients to ortho admissions.
Does it happen? Mythical admissions that happen. So I guess I don't know that I can do this under 60 seconds. Admissions to orthopedic surgery, typically seen in patients that have absolutely zero medical complications, which in other words is no patients.
Okay.
All right.
How about the other way around, though?
Tell me what you mean.
Ortho admitting their patients to you.
Oh, it's safe medicine. It's a co-management by medicine team to ensure that patients have a safe, effective hospitalization and safe and effective transition home.
Are those ever tense conversations that you have with your orthopedic surgery colleagues, or is that something that I made up in my head?
I've given up at this point.
Well, blessedly, I don't do inpatient medicine.
Yeah, Paul doesn't do inpatient for the past few years. I still do inpatient. I rarely push back anymore. Like if the surgical service wants the patient admitted to medicine, usually that means they're better served there. But they usually have some kind of medical problem. They'll say admit to medicine, we will consult, and that just means that we do the admission and discharge paperwork for them, basically, and we manage all the medical problems.
Okay.
But yeah, as you get older, you just stop fighting some of these fights that just, you're going to lose. The orthopedic surgeons are much more valuable to the hospital than us as hospitalists. So you just got to take it on the chin.
There was an ICU doc, a cardiac ICU doc that Matt and I worked with when we were in residency. And, when you're a resident, any admission is just another barrier between you and sleep or you and getting home. But, but this guy, anytime the phone would ring, he'd pick up and you would just see him be like, nope, we're happy to have him. Like no interrogation, no question. And he actually became a real inspiration to me. Like he just recognized that patients need care.
Yeah.
and who better than medicine? So it's, if not us, then who? So why fight that fight? The patient's going to be better off with us. So it's yeah, I'm with Matt. It's even when I was doing inpatient stuff, there's no point in fighting. I think the patients get good care with medicine. Otherwise, what are we doing here?
I love that. That's a good perspective. All right. So, Paul, I'm going to give you another one then, since Watto gave a lot of that answer.
Stole from the point. Sure.
All right, here we go. Urine electrolytes.
Oh, urine electrolytes are when you measure electrolytes in the urine. And when I do that specifically, it means the patient is in deep trouble and headed for a nephrology consult.
Explain that to me. Why are they in deep trouble?
Oh, I feel like it's one of those things. If you check your own electrolytes when you're just not really sure what's going on. So there are certain things I feel very confident in, but once I start to look at what's actually in urine from an electrolyte standpoint, then I'm worried about things like SiADH and other sort of more exotic things. So at that point, if I'm looking, it means I don't know what the answer is, which means the patient is not in trouble necessarily, but it just means that I need more help than my own brain.
Gotcha. Okay, so it is a sign that there's some unknowns and things could be going better in terms of
the great Donald Rumsfeld. Sure.
Yeah. Okay.
50 seconds on that one. Not bad.
That was good. I was when you throw out electrolytes to an internal medicine physician, it's a mixed bag on how long they'll talk. Okay. All right. Watto, types of rounds. Let's see. How about rounding
types
strategies?
Of rounds.
Rounding strategies.
Bedside rounds. The two types of rounds I practice: bedside rounds, where you go around and see the patient at the bedside. The students and residents present at the bedside, and then maybe once out of every 2 weeks that I work with the residents, I will try to have some breakfast rounds where we sit at the breakfast table and talk about the patients before we go to see them. Those are the two types of rounds I would most highly recommend to people.
What is more popular, would you say, among the trainees?
I mean, breakfast rounds is basically me pandering to the residents to give me a good evaluation.
Whatever works.
Yeah, fair enough.
Got to know your audience.
Yeah, free food is always a good idea.
All right, I have a few more. Paul, give us your 60-second explanation of rhabdomyolysis.
Oh, gosh. So rhabdomyolysis, so the problem here, Will, is that rhabdomyolysis is cool. So it was actually first evaluated or first really well described. I want to say it was in World War II as a result of crush injuries that happened during the bombing of London. And so this is what was first characterized. And so what they were seeing is this massive breakdown of muscles that was leading to things like kidney failure. So they would actually track urine output. And I can't remember what electrolyte levels they were actually tracking at that time. But in any case, rhabdomyolysis is typically caused by breakdown of muscle from any number of reasons that then leads to other metabolic complications because of all the myoglobin that's kind of floating around in the bloodstream. But the history is super neat.
Yeah. It's actually, I'm learning that there are so many advances and things in medicine that we've discovered through like war, which is unfortunate, but it's like, so let me give you an example in ophthalmology from World War II. Now,
yeah, please.
Everybody gets cataract surgery. They get an artificial lens that goes in their eye. This lens is made of plastic. Well, the first artificial lens that was ever put in someone's eye was made out of PMMA, which is really tough, hard plastic. And the reason that they knew this would work was because there was this one ophthalmologist who saw British RAF like fighter pilots who came back, and they had shrapnel injuries where the cockpit glass, plastic, whatever it's made of, embedded in the pilot's eye, and the eye did okay. It didn't. There was not this intense inflammatory response.
Oh wow!
They were able to leave those little pieces of plastic in the eye, and it didn't cause any problems. And so they ended up making the first artificial lenses out of whatever that material was, which I think it was probably PMMA.
How about that?
Yeah, there you go. That's the birth of modern cataract surgery, basically.
Fascinating.
Spectacular.
Well, me and Paul appreciate it. All right.
Yeah.
So, I don't know. All right. Watto, Wait,
Paul, you really took the
yeah.
bait on that last question. I was worried about the 60-second time limit.
No, he was in at 35 and a half.
It's good. It's good. Okay. All right.
In fact, I think you talked longer.
I probably did. All right, get me on cataract surgery. I'll talk like an internal medicine doctor. Okay. All right. Watto, tell me about the last ophthalmology consult you called.
Oh, geez. It was probably for someone with new floaters or flashes, which I was told by an ophthalmologist is like a heart attack of the eye. It's like you gotta get them there quickly. Maybe not within 90 minutes, but you gotta get them there quickly. So usually that's what it's for. I just make sure that they're getting in to see the person within 24 hours if someone says I have new floaters or flashes.
Yeah, that's good. Nice.
All right. 25 seconds.
20. That's absolutely 24 I would say 24 to 48 hours is okay for flashes and floaters. But yeah, you right on the money. What I say is for local, private practice ophthalmologists or optometrists, they see flashes and floaters as well. They can do a good exam of the back of the eye. Any private practice should be able to get a patient in within 24 hours, maybe 48 hours. Anybody who says that it's going to be like more than that, they don't know how to run a private practice. So that's my I've got a bit of a, what do you call the thing?
Chip on your shoulder?
Not a chip. The thing you step on.
Soapbox.
Soapbox. That's the one. God, words. It's embarrassing not to have words, and I'm speaking to interns. I don't know.
I saw the pressure. You're feeling a little bit like, nervous in front of these people.
I am a little nervous about it. I'm
You're
hearing
just a
all of these
lowly
things.
ophthalmologist.
I'm just a lowly ophthalmologist. That's right. Okay. All right, Paul, I got one more for you. Okay. All right. This is one that was recommended from Twitter. Stress dose steroids. Is that a thing?
I'm just going to make it easy on myself and just say high dose steroids and just leave it at that.
Oh, okay. All right. High dose steroids. Paul, are you with us?
Oh, I'm with you. No, that was as much as I was going to say. I'm just going to say very high dose steroids and leave it at that. Yeah. Listen, you can give me plenty of rope. I'm still not going to hang myself. Like that's.
Okay. All right. That was
the best.
that was really good. I was like, they were waiting for something and nothing was coming, and so we were done. All right. The last one. Where are we with acronyms? Actually, let's do this one. How about this? What is your favorite internal medicine acronym, mnemonic, that you use? Do you have one of these that you use still?
I do not like them. Like if the funniest one, I will tell you my favorite one because it's so terrible. And I apologize to the person who came up with this. It's called Snoop 10, and it's for migraine headaches, like for when you should be worried about like secondary causes of headache and when you should think about like getting imaging. And Snoop 10 has like, it's spelled Snoop, SN, with like 5 O's, a P, and a 10. And it's just like, it's these 10 things that you should think of that might cause secondary headaches that are like alarm features. And it's just such a long list. Like, who is remembering? Like, it's the dumbest acronym. Like, it doesn't help anyone remember it. It's just someone just, probably spent like a couple hours writing out everything they could think of. And then they tried to like force it into an acronym. We come up with this a lot with trial names, right, Paul? Where they're just like, this is the prevent trial. And then you like look and they just, where they get the name prevent out of the letters of the trial is just, it has nothing to do with it. So yeah, Snoop 10, look it up. It's terrible.
I think that's the most they've had to say about any of these topics.
Yeah.
Was the egregious use of
I guess that's my
acronyms.
soapbox.
No, I'm with Matt. Because my brain is broken. Like even when I was studying for step 1, I at the time I was like, I will just learn all of medicine. Like I'm not going to use these, mnemonics because I am not a child. And then I did not do great on step 1. But even still, like I can't. I don't remember what the mnemonic stands for if I try to do it, and then I get myself into trouble. So I tend to not use them any more than I need to.
I tell you, I'm also not a mnemonic guy. My brain, I don't know. Some people just swear by them. It's like a big part of learning in med school and even in residency, but I don't know. Maybe it's good for test taking. I guess it's probably not as useful when you're out in the
Yeah.
real world practicing, right? Because like I should just go and look it up.
Right. Yeah, that's exactly it. Now, up to date exists for a reason. I don't need to remember Snoop 10. Like that's
Right.
Uh,
All right. And then what I want to finish with here, I got one more question for the two of you is, you've been really at the forefront in a lot of ways of this just free medical education, just thinking about different ways to educate, the next generation of physicians. Do you, where do you see it going? I guess, like, what are the pain points that you think we can, maybe I'm asking several questions here, but maybe I'll just leave it. I'll leave it vague and just say, where do you see medical education going in the future?
Paul?
yeah, I have a bazillion thoughts on this. Like, I think there's a national trend towards sort of shortening the preclinical years and getting people more clinical exposures, which I think is really meaningful and valuable. I think historically, and I'm not sure this answers your question specifically, there have been two different curricula happening at the same time in undergraduate medical education specifically. So the medical students will go to the lectures and they'll hear from people and take notes, and then they'll study for the step 1 and step 2 examinations, which is an entirely different studying. They're using Anki decks, they're using Sketchy Micro, they're using resources that we're not actually using in the medical schools. These poor students have to put themselves through two different curricula in order to survive undergraduate medical education. And I think my hope is that we're going to start to see those two curricula start to converge. And as we're more forward thinking, we'll think about ways to actually make the undergraduate curriculum meaningful and directly relevant almost immediately, as opposed to sort of the pure
Mm.
abstraction that it is right now. So, because right now they have to know what's on the lecture, and then they also have to study for the board exams, and those two things are often not concordant. And I think that's, people are being very thoughtful about actually trying to merge those things and make things more directly clinically relevant, which I think is way, way overdue. So that's my hope and kind of the trend that I see. And I'm not sure if that answers your question specifically.
Yeah, no,
or
that was
not.
great. Absolutely. Watto, what do you think?
Yeah, Paul, that was a good answer. The other thing I think about, obviously you got to mention AI with this, is like, how is that going to factor in? Because it's going to be just so much quicker. Your iPhone has OpenAI or whatever built into it, and then you're just going to ask
Mm.
ChatGPT. So you're still going to need to learn medicine so but it's going to be like interfacing with these technology tools for learning is, I'm curious to see how that plays out, and whether or not a medical podcast will even still be relevant, Paul. If people are just going to have, like, I mean, they already have a supercomputer in their pocket, but I don't know how what we do right now is going to evolve as that gets better. So that's what I'm slightly worried about as far as the longevity of our podcast, and also just curious as to see how that plays into medical education.
No, I mean,
I
it's
I'm
so I could, sorry, I apologize. I could talk about this for
Go
hours,
ahead.
but I think you, like the AI, like the whole key is being able to ask the question that is most meaningful to it to get the answers that you need. Like, you can't just be like, what is wrong with this patient? Have it barf out some information that's useful, because it lies and makes stuff up. Like, you have to know what the prompts are before you can even get there. So you still need some kind of framework. I will say, along those lines, Matt, with AI, you made me think of the other thing that I think is exciting about medical education. As many thoughts as I have about maintenance of certification and the ABIM exams as they exist, like, I don't know what you have to do for ophthalmology, but the longitudinal knowledge assessment that we're doing now, or you at least have the option where it's open book, like you can go and look things up
Mhm.
while you're taking the examination to maintain your certification, is so much closer to the way that we practice than sitting in a classroom and trying to regurgitate, all the knowledge in your brain for 10 hours. So I do think the move towards test taking, reflecting more how we practice, as opposed to this artificial environment that is just purely a test of knowledge, which is not how you actually take care of patients. So I'm assuming that sort of assessment
Yeah.
and education will also be moving in that direction too. But I don't think, Matt, we're going to be irrelevant, at least not for the next 2 years or so.
I think you underestimate, the people that listen, just Paul, for your personality. I think you're
Oh, that
Watto,
can't be a thing.
like okay, you're fine. But Paul,
Agreed.
really, just great answers, you guys. Definitely, Watto, great points about AI. But neither of you mentioned like teaching the fundus exam any better than we currently are, which I think is really probably the biggest thing that's limiting medicine at this point from just really improving. But maybe that's just me.
I'm pretty sure it is literally just you.
No, I will tell you, just again, another tip to the medical student listeners out there. Like if you say, and I performed a fundoscopic examination, and even though I'm not great at it, it looked okay to me. You will be carried around on the shoulders of your internal medicine attending like a conquering hero. Like it just no one does it anymore. But if you do it for a headache or high blood pressure, at least if you try, like they will think you are the greatest student to have ever walked into their institution. So I'm actually with you. I don't think we do it nearly enough.
Paul, my man, I like you. That's fantastic.
I'm going to start carrying around, Will, just for you, I'm going to carry around dilating drops. You'll just have to tell me what those are. And then I'm going to just dilate eyes and look at the back of people's heads when they come in with, any kind of CNS complaint.
Hey, I've been on the warpath to get people comfortable dilating eyes.
Well, you should give them your tip for using the slit lamp.
I mean, I don't think do you guys have access to a slit lamp? Probably not. I mean, usually
but
in the
it
hospital,
works for whatever, really. Any kind of how do you even say that word? Ophthalmologic.
Yeah. Well, what I tell the emergency residents, like when I speak to emergency physicians, just all of them, is that when you sit down at a slit lamp, the first thing you say is, "Who messed with this thing?" And to try to like give yourself some time to figure out. You could do the same thing with a direct ophthalmoscope.
Yeah.
Like you say, all the settings are wrong on this. Oh man. And then it just buys you like a little bit of time before the patient realizes you don't know what you're doing. It's just a little tip just to make people a little bit more comfortable and not so scared,
That is so smart.
Yeah.
Yeah, as you're shining the thing into your own eyeball, you're like, oh gosh, someone had this all backwards.
Exactly. Well, Watto, Paul, thank you so much for coming on. So we got just again talk about the Curbsiders. Everybody needs to check it out. Where can people find it?
The Curbsiders on Facebook, Instagram. I don't know why I said Facebook, Twitter, and now known as X. And then
MySpace.
We have. If you really want bonus episodes and ad-free episodes, patreon.com/Curbsiders is where you can get all our stuff and a lot of cool bonuses on there too.
Awesome. And just, I love what you guys are doing, just approaching education through a slightly different way than we're used to seeing. And it's engaging. I loved being on your podcast. It was a lot of fun. And just the breadth of topics you cover. And I think you've probably done a lot to help just show people what primary care is like in internal medicine, and I think you've done a lot of good for medicine. So please keep it going. I don't care what AI does, as long as you keep doing the Curbsiders. I think it's really important to everybody.
No plans to quit right now. We'll keep going, Paul. Right? We got to get at least 10 years. We got to go to at least 10 years, right, Paul?
Wait, how far are we in?
We're September 2025 would be 10 year. 10 years would be September 2025.
Oh, okay, yeah, that we can do. That seems achievable.
You've got that much gas left in the tank.
That's right. Well, thanks again, you guys. It was a pleasure.
Oh, likewise. Thanks so much for asking us.
Thanks for having us.
Hey, Christian, you know how it's kind of hard to make friends in your 30s?
Yeah, because you don't see anyone or go
Life
anywhere.
just gets complicated, right, with kids and work.
Right.
Well, I brought some friends for you.
Oh, who?
Yeah. Demodex.
Okay.
Demodex mites.
You shouldn't have.
They can just live with you,
Just
on you, all over you. Yeah.
Okay.
What do you think? Aren't they cute?
Well, these ones are, but I don't think the real ones are quite this cute as the stuffed ones.
They'll listen to you. They'll listen to your secrets.
Oh, and keep
Yeah.
them locked away in their ribbed bodies.
So these little guys, they live on your eyelids, and they can cause a disease called Demodex blepharitis.
Yeah, like itchy, crusty, red, flaky,
irritated eyelids.
Yeah.
That's right.
No one wants that.
No one wants it, but it's important that when people hear this, they don't get freaked out by this.
Mm-hmm.
You got to get checked out.
True.
Right, checked out, not freaked out. Because, coming to the eye clinic, we'll talk to you about Demodex and Demodex blepharitis and see what's going on. To find out more, go to eyelidcheck.com. Again, that's EYELID check.com to get more information about Kristen's new friends here, Demodex blepharitis. So, Kristen, given what you know about internal medicine physicians, do you think I could have been one of them?
No.
Why?
You don't like words enough.
Like
You don't like,
talking?
you don't like talking. You don't like academics.
You can't say I don't like talking on a podcast.
Well, it is a mystery how you ended up with a podcast, but generally speaking,
We have some very persuasive producers.
that and you, I had to come on to help fill the dead space from when you didn't want to talk. Yeah, I'm not
Okay.
wrong.
All right. You've got a point.
People may not know this about you because you put on this like performance when you're Dr. Glaucomflecken, but Will Flannery, MD, does not really enjoy the long drawn out conversations. Listen, don't ask questions that you don't want to know the answer to.
I feel like once I get to know somebody, I do open up and I can talk.
No.
Okay.
I have been married to you for 15 years almost. No, you hate conversation. It's got to be, I have learned, in fact, over the years, some tips and tricks for like dealing with you. And one of them is I have removed any unnecessary words from any sentences. Like, I don't send you sentences. I send you, like, remove any be verbs. Remove any the, a, and, no,
Articles,
unnecessary.
yeah.
Just like 2 to 3 words.
Right.
You got the noun, you got the verb, and then you got the punctuation mark that indicates whether it's a question or not. Sometimes you don't even put in the punctuation.
Okay. Well, to all our former or future guests on this podcast, I do like having conversations with you all.
Yeah, it's not that you don't like the people.
Yeah.
It's that you don't like talking. You don't like moving your mouth and sounds come out.
And so, yeah, that is hard sometimes.
Yes.
Okay. All right.
You're making it seem as though I'm just like insulting you or being hard on you.
You're not.
You know this about yourself.
I know.
Admit it to the people.
Maybe I just wish it wasn't true. All right, because
doesn't mean that you're not friendly or something. You're a man of few words if you have your druthers.
Okay. You guys get what she's saying? Hopefully. All right.
I should do a screenshot of like our text exchanges and people will see what I mean.
Right. Show Patreon. All right. If you guys want to see our private texts to each other, join Patreon. By the way, we have a Patreon. Did you know that? Fun perks, bonus episodes, or react to medical shows and movies. We're there. We're active in it. We're sharing our deepest, darkest secrets with you all, apparently. And so you should definitely come check it out. You can also hang out with us in our Human Content Podcast family. We're on all the social media networks at Human Content Pods for that. And also, let me shout out to all the wonderful listeners leaving feedback and reviews.
Love those reviews.
Yeah. If you subscribe and comment on your favorite podcasting app or on YouTube, we can give you a shout out. Like @Tony P on YouTube said, "This was such a delight to listen to. If it was 3 hours long, I would listen to it all."
Well, we've just established that it will not be. But thank you, Tony P.
Full video episodes are up every week on our YouTube channel at Glaucomfleckens. We mentioned the Patreon. We also had patreon.com/Glaucomflecken. That's where you can find it, by the way. We also have Patreon community perks. Let's do that. New member shout out. Michelle W., Jeff V., and Esperanza I. Welcome. Thank you for joining our little community here. We all love talking to each other. Shout out to all the Jonathans, as always. A virtual head nod to you all. Patrick, Lucia C., Sharon S., Omar, Edward K., Stephen G., Jonathan F., Marion W., Mr. Granddaddy, Caitlin C., Brianna L., K. L., G., JJH, Derek, and Susanna F., Mary H., Jenny G. A., Muhammad K., Aviga Parker Ryan, Muhammad L., David H., Jack K., David H., Gabe, Gary M., Medical Meg, Bubbly Salt, and Pink Macho. I tried to cover it up that time. There's got to be some kind of psychological thing going on. I can't get the G
You really
and the J.
want that to be Jenny G.
I wonder if it would change if I moved Jenny J to a different part of the script. I don't know.
I don't see why it
Patreon
would.
roulette time. Random shout out to someone on the emergency medicine tier. Sally. Thanks, Sally, for being a patron. And thank you all for listening. We're your hosts, Will and Kristen Flannery, also known as the Glaucomfleckens. Special thanks to our guests, the Curbsiders, Dr. Matt Watto and Dr. Paul Williams. Thank you. Our executive producers are Will Flannery, Krista Flannery, Aaron Corney, Rob Goldman, and Shanti Brook. Editor and engineers Jason Portizo. Our music is by Omer Ben-Zvi. To learn about Knock Knock Hi's program discipline, ethics policy, submission verification, and licensing terms, and HIPAA release terms, hey, that's a lot of words for me.
Yeah, and what do you do every time we finish this part?
I think I'm saying them very fluently and excitedly.
I'm not saying you're not fluent.
You can go to Glaucomfleckens.com or reach out to us at knockknockhigh@human-content.com with any questions, concerns, or fun medical puns. Knock Knock High is a human content production.
Knock, knock, goodbye.
Kristen, what would you say is the most important part of my job as an ophthalmologist?
Helping people see better.
That's a much better answer than getting home at 5 o'clock every day.
Yeah. I mean, I do like that part too. That's good.
But the most important part of my job is not clinical documentation.
Right. That is the most worst part of your job.
I have to do it. It's important, but I like doing other things too, like restoring eyesight,
Yeah.
talking to my patients,
Right.
developing those relationships.
Looking at them in the eyes.
Yes. You know what helps me do that?
What?
The DAX Copilot from
That's
Nuance. Yeah, it's ambient technology, AI powered. It helps me actually like maintain those relationships. I can actually develop a rapport with patients that you can't do otherwise.
People tend to prefer it when you're looking at them when you talk instead of typing.
80% of patients say their physician is more focused with DAX Copilot. 85% say their physician is more personable and conversational.
Well, how about that? You could use a little help in that area.
I need a little boost from time to time. To learn more about the Nuance Dragon Ambient Experience or DAX Copilot, visit nuance.com/discover DAX. That's nuance.com/discover DAX. Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Hope you subscribe, leave a comment below. Let us know what you think.